In the second pressing, I'm going to talk about the voided midstream urine culture and acute cystitis in premenopausal women. So, this acute cystitis is a disease caused by germ, usually a bacteria, as Escherichia coli, that enters the urethra and then the bladder. This bacteria can lead to infection, and most commonly in the bladder, but also this can travel from the bladder to the kidneys and makes a more harmful infection. Women are more propensible to acquire this type of disease and infection because their urethra are more short. Women tend to get infections more often than men because their urethra is shorter and closer to the anus, and for this reason women are more likely to get an infection after sexual intercourse or when using a diaphragm for birth control. Menopause women also increase the risk for a urinary tract infection because they leave this canal free for bacteria to come. One of the causes of this cystitis is determined on the basis of cultures of voided midstream urine, but few data guide the interpretation of such results, especially when gram-positive bacteria grow. The symptoms are cloudy and bloody urine, which may have a full or strong odor, low fever. Not all of the patients will have this fever, pain or burning with urine, pressure or cramping in the lower abdomen or back, usually in the middle abdomen of the umbilical zone, a strong need to urinate often, even right after the bladder has been emptied. We have exams and tests to see what type of bacteria is colonizing in the urethra, bladder, or kidney. So this use a urine test. A clean catch may be done to identify the bacteria in the urine to make sure the correct antibiotic is being used for treatment. In this case, the most common, as I said, is Escherichia coli, and maybe a cephalosporin or a gentamicin. It's good for it. This bacteria cultures of voided midstream urine in healthy premenopausal women with acute uncomplicated cystitis accurately showed evidence of bladder with Escherichia coli, but not of enterococci or group B streptococci, which are often isolated with Escherichia coli but appear to rarely cause cystitis by themselves. So this is all for this press. For now, I have a case of a premature newborn boy with respiratory distress and also hypernatremia. This case starts with a newborn boy who was admitted to the neonatal intensive care unit (NICU) of this hospital because of respiratory distress. The patient was born at a gestational age of 29 weeks at another hospital by cesarean section for breech presentation, premature labor, and rupture of membranes and approximately 2 hours duration. He weighed 1,275 pounds and appeared vigorous with spontaneous respiration the 1 minute and 5 minutes. But shortly thereafter, subcostal refractions developed, and this with an analysis of umbilical arterial blood, it reveals a pH of 7.35, a partial pressure of oxygen of 47 of pressure, a partial pressure of carbon dioxide of 22 mercurial millimeters, and continuous positive airway pressure was administered, and he was transferred to nursery. Temperature is important because it was 37.2 degrees, under radiant heat, and the blood pressure it was 5844 mercurial millimeters, and the pulse 119 beats per minute. The oxygen saturation goes to 94 to 96%, while the patient was breathing 50% oxygen with CPAP. And also the glucose level at blood was 72 millipounds per deciliter, 4 millimole per liter. He was transferred to the hospital 1 hour after the birth to the Mass General Hospital for Children. NICU transport team arrived at the other hospital. So once it was examined, the patient was non-dysmorphic and the skin was pink and well perfused. There were moderate subcostal retractions, shallow respirations, and bronchial breath sounds that were slightly diminished in intensity. The remainder of the examination was normal for the gestational age. So once of all it was done, these exams, tests, and all of this, the baby starts to in the NICU, in the NICU, to start his treatment with corticoids and some kind of chirurgical interventions. So he developed better his lungs and gets off his barely alkalosis, breathing alkalosis. So he starts to improve his type of respiration, so he gets better after these interventions. So from now on, I have a randomized trial of TAS 102 for refractory metastatic colorectal cancer. So this type of cancers done in the colon can do metastasis, can be metastatic. So at the background, I can say that early clinical trials conducted primarily in Japan have shown that TAS 102, an oral agent that combines trifluridine and tipiracil hydrochloride, was effective in the treatment of refractory colorectal cancer. So we can use a phase 3 trial to further assess the efficiency of and safety of TAS 102 in a global population of such patients. So the method was a double-blind study that they randomly assigned 800 patients in a 2-1 radio to receive TAS 102 or placebo. The primary endpoint was overall survival. The results was that the median overall survival improved from 5.3 months with placebo to 7.1 months with TAS 102, and the hazard ratio for death in the TAS 102 group versus the placebo group was 0.68 evenly, 95% confidence interval, 0.58 to 0.81, and the liberty degrees was minor to 0.001. So the most frequently observed clinically significant adverse events associated with TAS 102 were neutropenia, which occurred in 38% of those treated, and leukopenia, which occurred in 21%, and 4% of the patients who received TAS 102 had febrile neutropenia, and one death related to TAS 102 was reported. The median time to worsening performance status, a change in Eastern Cooperative Oncology Group performance status on a scale of 0 to 5, with 0 indicating no symptoms and higher numbers indicating increased degrees of disability, from 0 to 1 or from 0 or 1 to 2 or more, was 5.7 months with TAS 102 versus 4.0 months with placebo. The hazard ratio was 0.66 and the confidence interval was 95% and 0.56 to 0.78, and the p was minor 0.001. The statistics says that colorectal cancer remains one of the most deadly cancers in the US, and the researchers are making steady progress against this disease. New drugs allow people with even the most advanced metastatic disease to live longer. Admittedly, there is no cure, and the improvements, which can add several months to a patient's life, may seem modest. The treatment was with Avastatin. Is modeled after the antibodies that naturally protect the body. It blocks the effects of a substance in the blood that helps tumor grow new blood vessels, and also with chemotherapy. This Avastin helps interrupts the generation of new blood vessels, so it means that this new tumoral mass, can grow because it won't have enough nutrition, because it won't be so irrigated to receive this nutrition. So in conclusion, I can say that patients with refractory colorectal cancer, TAS-102, as compared with placebo, was associated with a significant improvement in overall survival. Thank you. So from now on, we will check the guts and we will explore our microbiome. First of all, I can say that the microbiome can be divided in four rings, that are archaea, bacteria, eukarya, and viruses. In the human microbiome, we have some pros to us that are protected from toxic substances such as some medicines, some drugs. It helps in digestion, such as the bacteria help us to K vitamin and some minerals, and also it helps us to determine diet factors, such as some bacteria and parasites help us to digest some cellulose that are impossible to digest for us. Also, we can say that we have cons and have pathological bacteria, pathological parasites, and viruses. So the microbiome is only the organisms that helps us to improve our lifestyle, and they get some kind of benefits from us, like house and life. The development, we develop our microbiome from environment because of we have environmental contact with our skin, with our oral cavity, with the vagina in women's, and with the fecal and gut in all people. So we have some microbes data that we can carry up to 2 kg of microbes in our gut. Within the tens of trillions of microorganisms that live there are at least 1,000 species of bacteria, consisting of over 3 million genes. So the human gut microbiome helps us in health because, according to the American Physiological Association, or APA, gut bacteria produce an array of neurochemicals that the brain uses for the regulation of physiological and mental processes, including memory, learning, and mood. In fact, 95% of the body's supplies of serotonin is produced by the gut bacteria, according to this association. Also, it helps us in nutrition. According to the Mayo Clinic, a healthy diet can encourage the presence of good gut bacteria. They note that consuming fermented foods such as miso and sauerkraut increase the level of fermenting bacteria in the gut. In addition, fruits and vegetables contain fibers and sugars that can boost the health of gut bacteria. So this is all that I can say for the microbiome of gut. Thank you very much.